Welcome, and thank you for standing by. At this time, all participants will be in the listen-only mode. After the presentation, we will conduct a question-and-answer session. At that time, to ask a question, dial star 1 on your touch-tone phone. Today's conference is being recorded. If you have any objections, you may disconnect at this time. I would now like to introduce your host, Dr. Shakiba Henderson. You may begin.
Good afternoon. My name is Shakiba Henderson, and I'm an obstetrician gynecologist and medical epidemiologist in the Division of Reproductive Health at the Centers for Disease Control and Prevention. I lead the state-based perinatal quality collaborative activities in our division, and I'd like to welcome you to the second presentation in our second series of webinars we are sponsoring on perinatal quality collaboratives. Today's presentation is about severe maternal morbidity, including its measurement at both the population and facility levels, recent trends, and an overview of national projects designed to address severe maternal morbidity. Our presenters today are Drs. William Callahan, Andrea Crianga, and Elliot Main. At the end of all the presentations, you'll have the opportunity to ask questions and participate in the discussion. A recording of this webinar will be archived on our webpage at www.cdc.gov/reproductive health/maternal infant health/PQC. Downloadable handouts are also available and may be accessed by clicking the Handout tab at the upper right side of your screen, and then selecting the files you'd wish to download to your computer. For additional information about severe maternal morbidity in the United States, you can also go to our webpage at www.cdc.gov/reproductive health/maternal infant health/severe maternal morbidity. Our first speaker today is Dr. William Callahan. Dr. Callahan is an obstetrician gynecologist and the chief of the Maternal and Infant Health Branch in the Division of Reproductive Health at the Centers for Disease Control and Prevention. In this position, he provides scientific leadership to a group dedicated to research and public health surveillance in the areas of maternal morbidity and mortality, infant morbidity and mortality, preterm delivery, and pregnancy complications, particularly as they relate to subsequent risks of chronic disease. During his tenure at CDC, he has been an author on numerous peer-reviewed papers, presented his work in the field of maternal and infant health at national meetings, and provided technical assistance to states engaged in the identification and review of maternal deaths. I will now turn the presentation over to Dr. William Callahan.
Hi, good afternoon, and welcome to this webinar from Thawing Out Atlanta. Today I'd like to talk a little bit about how we've been thinking about severe maternal morbidity over the years, and specifically I think how we can account for it. I think amongst all the speakers you'll see that there's going to be probably a little bit of overlap in our presentations, but hopefully at the end you'll see a degree of cohesiveness around looking at maternal morbidity that heretofore just really hasn't existed. There we go. So we're going to talk about a little bit, some historical context, just a little bit, how we can account for it, and then talk a little bit about looking at severe maternal morbidity at the facility level versus national surveillance, because the issues are a little bit different. Historically, this is just to remind you that we've been looking at maternal mortality and morbidity, thinking about it for a long time. This is from 1916. It was a report that Dr. Grace Meeks did when she was at in the Children's Bureau, which was then housed in the U.S. Department of Labor. And she was charged with looking at the problem of infant mortality. And what she concluded at the end of the study is that the issue really is around care of the mother, and pointed out that maternal mortality is preventable. No available figures show a decrease in the United States in recent years in those times, and that certain other countries exhibit more favorable rates. And in many ways we can say, make a similar statement today, although obviously the magnitude is different, and I think that Dr. Kriyango will probably allude to that. So again, just to provide context about the number one indicator for maternal health, this is pregnancy-related mortality in the United States based on Pregnancy Mortality Surveillance System housed in the Division of Reproductive Health. And as you can see, we've been seeing a substantial increase over the years. Some of that is related to better identification of pregnancy-related mortality, but there's also at least some strong circumstantial evidence that this represents a real increase. When we look at the causes of maternal mortality, we can see now that the leading cause of maternal death in the United States is cardiovascular disease, and then followed along with some of the other more traditional causes, although again, the non-cardiovascular medical diseases, other chronic diseases, are leading causes. We also see the typical things of infection and hemorrhage and hypertension during pregnancy and embolism. So while we are increasingly emphasizing this chronic disease component, women continue to die from things that they have always died from. This has been a big enough problem that 4 years ago now, almost to the date, the Joint Commission issued a Sentinel event report with regard to preventing maternal deaths, highlighting the importance of this problem and the increasing pregnancy-related mortality in the country. In the same sort of time frame, Mary Dalton has put out now several times the idea of the M in maternal fetal medicine, harkening back to the words of Alan Rosenfeld about the M in MCH on the global stage. She was and has been championing the return of the M in maternal fetal medicine. So it seems like this has been a hard problem, and the question is why is it so hard, or why the issue of maternal mortality, and this is leading into why we think that morbidity is something that's important to look at. Well, first of all, maternal deaths at the population level, from where we sit, are sometimes difficult to identify. We have problems with definitions, and this could be vital statistic definitions versus surveillance definitions. Some folks look at the temporal relationship to pregnancy, and classically that's been within 6 weeks, but we think that that needs to be extended, and we have extended that out to a year. And then trying to understand is the event of death really causally related to pregnancy, or is it something that the woman would have died from anyway? We try to look at it under the lens that if the woman had not been pregnant, would she have died? We also have the problem that there's multiple etiologies. So we're not dealing with a single disease. We're not dealing with just cancer or just tuberculosis or just like a lot of other things in public health. We're looking at the event of pregnancy, but there are a lot of reasons why women die. We know that reviewing deaths is a great way to try to help understand and design prevention, but reviews that really inform change are time-consuming. And lastly, quite frankly, maternal deaths are rare. There are 700 per year in the United States approximately, and we look at that in the context of other reasons that people die. There's 1,500 car crash fatalities in Georgia every year. There's somewhere in the neighborhood of 7,000 deaths from prescription drug overdoses among women. So we're looking at a very small segment of the population and their risk of death. And oftentimes it's hard to get a lot of resonance because of that small number. what I have advocated for is the fact that most of us that are doing what we do signed up to do what we do because this is what we care about, and it is our job and our opportunity to advocate for the prevention of maternal mortality and morbidity. So with that in mind, we do know that mortality is the tip of the iceberg, and there are many, many more women who suffer severe events. And our job is to try to understand how we can account for these, because we think that understanding what's below the tip of the iceberg it is important in its own right, but will also help inform what's going on in the part of the iceberg that we can really see, especially from a system standpoint. So the problem with looking at morbidity is that it's difficult to define. There's this broad range of complications and conditions, a broad range of severity that extends really from a perfectly well and healthy woman to death. In some place in that continuum, we're looking for kind of a place where we would say this is the group of conditions and problems that we want to look at. Obviously, if you line people up, sometimes you'll get debate over where that line can be drawn, just like any time in life that we draw a line. And we've also come to the conclusion that there's no simple set of metrics that we can capture all of maternal morbidity. The data that we need lies in different places, and the data has different levels of granularity. So we have been trying to emphasize the severe end. The concept of near miss has been put out there. It's a little bit more common, I think, in the British and European literature than it is in our literature. But basically, these are women who came very, very close to dying. Stacy Geller and Sarah Kilpatrick some years ago put together a construct and a set of indicators to identify women with what they call near miss or very severe morbidity. One of the problems with doing this in the way they did it is you need a variety of data sources or a dedicated perinatal database to identify those cases. And at the end of the day, this idea of near miss or very severe is made by expert opinion. Essentially what they did in their construct is they cast a broad net for women who appeared to have a severe event during their delivery hospitalization, and in reviewing those cases using their own clinical expertise, created a set of women that had, by their definition, near miss / very severe morbidity, and then set up a scoring system that would help identify them. It remains the best gold standard that we have for the entity that we're going to call near miss or severe morbidity, and I'll go into that in just a minute. They developed a 5-factor scoring system to identify them, and they used indicators of organ system failure, women who had extended intubation, women who were admitted to an ICU, women who had a surgical intervention that was not anticipated during their delivery, and women who had transfusion of at least 4 units of blood, greater than 3. So obviously, when we define near miss like this, it overcomes the issue of severity. We have a group of women who were really quite ill. But oftentimes, one of the problems with this, especially with the 5-category scoring system, it required multiple sources of information to identify them. Most of the scoring system factors are not available in the traditional administrative databases based on ICD codes. It may be less useful in smaller institutions where these are still going to be quite rare and not have the infrastructure to identify them. And it's going to be very cumbersome at the higher population level because of the lack of information in administrative databases. One of the things they did find is that they look at indicators for organ system. They perform pretty well by themselves, and we thought that it might be useful to look at administrative data for those indicators. transfusion of at least 4 units and or an ICU admission is also quite sensitive in the five-factor system, and you'll see how we consider that in a few minutes. And lastly, that system has been recently validated. You and others at Northwestern last year published a validation of their construct, and it indeed works quite well now 10 years after the original publication. So we wanted to know if we could use administrative data to capture this, and we have been thinking about that now for really going on 10 years or so in various iterations. Most recently, we published severe maternal morbidity in the United States, and using data from the nationwide inpatient sample, we aimed to capture indicators of organ system failure, tied those indicators to mortality to try to validate how well the system performed, and to clean the data, imposed some length of stay criteria. In doing so, we were able to set up categories of women that we thought had severe morbidity based on either a very specific, rare, and what most people would consider untoward events, indicators of categories of organ system failure, or procedures that one would rarely anticipate during the delivery hospitalization. Using those indicators of severe morbidity, and I think Dr. Triangle will talk about that a little bit more, during that period from the late 90s to 2009, severe morbidity increased 75%. This was led by doubling in blood transfusions, acute renal failure, and aneurysms. We also looked at postpartum hospitalizations, and severe morbidity doubled during those. Large proportions of women who died in the hospital had those same indicators for severe morbidity, we think adding validity to the construct that we looked at. And in keeping with the tip of the iceberg metaphor, severe morbidity was 100 times more common than mortality. We know that transfusion was driving this, so we show here how severe morbidity, those that were identified only with transfusion and those that were identified without transfusion, showing substantial rates of severe morbidity even without transfusion, but clearly showing that transfusion, which we believe is a reasonable proxy for severe hemorrhage, was the driver for the increase. We also know that we don't have information on how many units of blood was transfused, so we think it's important to show these separately because there may be instances where transfusion of 1 unit or 2 units really wasn't that severe, and in fact was the appropriate thing to do to keep a woman from ultimately requiring 10 units of blood. We see something similar when we looked at the trend in postpartum severe morbidity. The other construct that's been out there, so I've showed you the Geller construct of severe morbidity, the way that we've looked at it from population, and the World Health Organization has also looked at severe morbidity. And as they propose it, this is largely based around organ system failure. And we think this is really quite good and accurate. One of the problems being that it's quite cumbersome to identify, clearly cumbersome to identify from administrative data because of the granularity of the definitions, and even in real time is going to be a little bit hard to implement. So when we think about severe morbidity, we have this problem of standardization of terminology. We have near-miss, severe morbidity, severe obstetric morbidity. We have the issue of should we count this at the facility versus the population, and we think both, but we may need different ways to look at that. Our construct is clearly retrospective because it's based on administrative data. In a facility, real-time identification, or at least as close to the time of the event, is going to be more important to identify in terms of doing timely review of care or root cause analysis. And there's going to be difference in availability of data systems. All of this needs to be looked at, though, in terms of how we would use the data for quality improvement. I'm unabashedly somebody who believes in counting, but I also believe that if you count and leave it there, you've really done not much. You haven't done much good. That you need to use the data to improve quality of care, and in this case, systems of care. And the other issue is, again, at what level we're going to review the cases. So we've made some propositions about how to handle this. And our current proposition is that we use, for national surveillance, we use administrative data. It's easily obtainable. Probably the most useful right now is in the nationwide inpatient sample from PARC. There are also the state inpatient databases that can be used for state surveillance. And Andrea Crianga will talk a little bit more about that, but our website now is posting national surveillance based on administrative data. Our second proposal for facility surveillance and review, and I do emphasize review, is the construct, the sort of shortened construct that Stacy Geller proposed and you validated of transfusion of 4 or more units. That says greater than 3. I think formally we're going to say 4 or more. It's clear, and or an admission to an ICU. These should be readily identifiable. They're not going to be good data systems to find those, but they will be able to be tagged, we think, in real time. As Elliot Main is going to talk about, we think the time is right. There's a lot of alignment. There's Mary Dalton's leadership in putting the MBAC and MFM. There have been proposals to establish maternal levels of care, similar to what we have for neonatal levels of care. We at CDC's DRH have been working with states for review of death under a maternal mortality initiative, and these same platforms may be useful for looking at severe morbidity. MCHB and HRSA has the National Maternal Health Initiative that has been rolled out, and AMCHIP's Every Mother Initiative. So with that, I think that provides an overall view of how we've been thinking and are now proposing to think going forward about maternal morbidity. And I'll turn this over to Dr. Crianga.
Thanks so much, Bill. Our next speaker is Dr. Andrea Crianga. Dr. Crianga is an obstetrician gynecologist and senior scientist in the Maternal and Infant Health Branch, Division of Reproductive Health at the Centers for Disease Control and Prevention, where she serves as the lead for the National Pregnancy Mortality Surveillance System and coordinator of perinatal substance abuse activities. Her research interests include maternal mortality and severe morbidity, disparities in maternal health, and the quality of obstetric care both domestically and internationally. Dr. Crianga.
Thank you, Kiva. Good afternoon. Over the next 20 minutes or so, I'm going to try to make CDC data and our measurement concept even more interesting and answer the following question. Why is pregnancy getting safer for women in the United States? Worldwide, over 200 million women become pregnant every year. An estimated 6.6 million pregnancies occurred in the United States in 2008, of which 4.3 million were live births, 1.2 million were induced abortions, and 1.1 million were fetal losses. While pregnancy is a physiological state and most pregnancies are not complicated, the perinatal and postpartum periods are a time of risk for women everywhere. Some pregnancies are complicated by either non-life-threatening or potentially life-threatening conditions. From a measurement point of view, a woman with a life-threatening condition will become either a maternal near miss or a maternal death. And Dr. Callahan has already walked you through the definitions for both. It has been estimated by UN agencies that about 15% of all pregnancies are complicated by potentially life-threatening conditions. Estimates of maternal near miss vary widely depending on the definition and identification criteria that is being used, and worldwide an estimated 287,000 women die from pregnancy complications every year. In the United States, there were 659 pregnancy-related deaths among the 6.6 million pregnancies in 2008. So to answer my question, I'll follow a similar format as Dr. Callahan, and we'll start by talking about maternal mortality. In the United States, availability of data from the National Vital Statistics System allows us to look at trends in maternal mortality throughout the 20th century and until 2007. Shown here is the important decline in mortality from over 800 deaths to about 15 deaths per 100,000 live births between 1900 and 2007. The big bump observed here is attributable to deaths due to the 1918 influenza pandemic. And the beginning of the important and monotonic decline in mortality coincides with the introduction of penicillin in 1928. A variety of factors, however, have likely contributed to this dramatic decline. Some were general factors, such as improved standards of living, better nutrition and sanitation, and some are related to changes in the structure of medicine, medical education, and medical advances. Acknowledging that vital statistics data failed to identify a considerable proportion of maternal deaths, in 1986, CDC has established enhanced surveillance for pregnancy-related mortality. And currently, this enhanced national pregnancy mortality surveillance system is the main source of maternal mortality data in the United States. The system uses the definition established by CDC and the American College of Obstetricians and Gynecologists for pregnancy-related deaths. Deaths are identified by states using keywords and ICD codes on death certificates, linkages between deaths of women and birth or fetal death records, reporting by facilities or providers in media reports. Copies of death and matching birth or fetal death certificates are sent to CDC, where clinically trained scientists use all the information available to pretty much recreate pathophysiological scenarios for each case and to assign the cause of death. This graph here shows trends in pregnancy-related mortality ratio in the United States between 1987 and 2009 using our surveillance data. And Dr. Callahan has already shown this graph to you, but I want to emphasize that pregnancy-related mortality has not declined in the United States for more than 25 years. Whether or not this increase is real or due to improvements in death ascertainment methods over time is unknown. What we do know is that in 1999, U.S. began using the 10th revision of the International Classification of Diseases to classify causes of death, and this revision includes an expanded, more comprehensive set of pregnancy codes. Also in 2003, a pregnancy checkbox has been introduced on the U.S. standard death certificate, and the purpose of this checkbox is to more easily identify death among women who are pregnant or postpartum. However, not all states have implemented this standard death certificate, and this is why our colleagues at the National Center for Health Statistics have not been reporting maternal mortality ratios after 2007. Interestingly, in line with the U.S. data, several European countries with enhanced maternal mortality surveillance, as well as Canada, have noted higher mortality ratios in recent years. Again, just like the trend in the U.S., these trends may be due to increased ascertainment of maternal deaths and may not represent a true increase in mortality. So clearly, pregnancy is not getting safer for women in the U.S. Why? First, as we all know, women are delaying childbearing, and pregnancy-related mortality increases with maternal age. By far, the most striking of all disparities in pregnancy-related mortality in the U.S. is the racial disparity. Black women have a 3 to 4 times higher risk of dying from pregnancy complications than white women, and this trend has persisted for over 25 years. While traditionally we have looked at racial disparities, or the gap between black and white women, we have recently examined pregnancy-related mortality by all race, ethnicity, and nativity, or place of birth, U.S. or foreign. And this table here shows age-standardized pregnancy-related mortality risk ratios for all groups of interest compared to the majority group of U.S.-born, non-Hispanic white women, used as a reference. Only foreign-born, non-Hispanic white women had a lower risk of dying from pregnancy complications than the majority group. And notably, Black women, both U.S. and foreign-born, had over 3.5 times higher risk of dying from pregnancy complications than U.S.-born non-Hispanic white women. Dr. Callahan has already told you a bit about causes of pregnancy-related death in the U.S. This graph here includes a little bit more data and shows changes in causes of pregnancy-related death between 1987 and 2009. The years shown here correspond to data in our CDC publication. The y-axis shows the percentage of all pregnancy-related deaths that are contributed by the categories of conditions shown on the x-axis. Overall, we see a decrease in the contribution of traditional causes of mortality represented by hemorrhage, sepsis, hypertensive disorders of pregnancy, and separated here by the red orange line, the emergence of chronic medical conditions, and especially cardiovascular conditions, as important contributors to mortality. And overall, for the most recent period examined, that between 2006 and 2009, 33% of all pregnancy-related deaths were attributable to cardio and cerebrovascular conditions, and an additional 12% to other medical conditions, therefore explaining together almost half of all the pregnancy-related deaths in the U.S. during this period. Similar trends have been reported in other developed countries, shown here cardiac diseases and other medical conditions were the leading causes of maternal mortality in the United Kingdom between 2006 and 2008. When looking at causes of pregnancy-related deaths in the U.S., again by race, ethnicity, and activity, cardiovascular conditions, shown here in orange, were the main contributors to mortality amongst U.S.-born non-Hispanic white and non-Hispanic Black women, while the main three traditional causes of maternal mortality, hemorrhage, sepsis, and hypertensive disorders of pregnancy, were the most important causes of pregnancy-related death for all other women, all the other groups of women. So we do have a striking black to white gap in mortality that cannot be explained using only the cause of death information that we have in our surveillance data. So the obvious next step for us in trying to understand this gap and to better understand overall trends in maternal mortality was to look at maternal morbidity. And Dr. Callahan has already told you how we currently account for maternal morbidity in the U.S. at the CDC. I don't expect you to read the information on this slide, but to summarize, WHO has proposed an approach for identifying maternal near miss, and Dr. Callahan and others at CDC have developed an ICD-based algorithm for identifying severe morbidity. And Dr. Callahan has already told you about these both approaches, but what I want to note again is that both use open system dysfunction criteria to identify severe maternal morbidity. And the reason why I didn't want nor expect you to read the information on the previous slide is that starting this year, we are putting our severe morbidity data on our website. So you now have easy access to both the algorithm that we use and also the most recent data points and overall trend in severe maternal morbidity. And we'll be updating the information on a regular basis. The webpage information is on the bottom of this slide. So how do we examine trends in severe maternal morbidity? We use data from the nationwide inpatient sample, the largest all-payer hospital inpatient database, representing a stratified sample of about 20% of community hospitals in the United States. By using analytical weights, we're able to provide national estimates of morbidity. This graph here shows trends in overall severe morbidity. These are women with at least one of the 25 severe morbidity indicators in the algorithm for 1,000 delivery hospitalizations. And Dr. Callahan has shown you data up to 2009. Here we have additional data that you can also find on our website. We found that severe morbidity during delivery hospitalizations more than doubled from 7.4 to 16.3 per 1,000 delivery hospitalizations between 98, 99, and 2010, 2011. Blood transfusion, hysterectomy, and eclampsia accounted for about 75% of severe morbidity consistently throughout the period shown here. At the current rate, severe maternal morbidity affects over 60,000 women in the United States every year. While we cannot directly compare the overall severe morbidity rate in the United States with the rate in other developed countries, such comparison is possible for eclampsia and hysterectomy, 2 of the 5 indicators included in the maternal mortality measure of the Europeristat project. In 2010, the rate of eclampsia ranged between 1 and 9 per 10,000 deliveries among the 20 European countries that provided this data to the project, while the 2010-2011 rate of eclampsia in the United States was 7 per 10,000 deliveries. Among the 17 countries reporting hysterectomy data for 2010, the rates ranged between 1 and 13 per 10,000 deliveries, while the corresponding 2010-2011 rate in the U.S. was 9.2 per 10,000 deliveries. Trying to explain racial ethnic disparities observed in mortality, we've examined racial ethnic disparities in severe maternal morbidity. We used 2008-2011 hospital discharge data from state inpatient databases in 7 states, all with over 80,000 annual deliveries, examined rates of severe morbidity by race ethnicity, and we fitted a regression model to examine the association between severe morbidity and race ethnicity, controlling for other factors. We found that severe morbidity, these are women with at least one of the 25 severe morbidity indicators in the algorithm, varies by race ethnicity, and disproportionately affects non-Hispanic Black women. The rates were 11.4 per 1,000 delivery hospitalizations among non-Hispanic white women, and 28.4 per 1,000 delivery hospitalizations among non-Hispanic Black women. The rates of 22 of the 25 indicators of morbidity were highest among non-Hispanic Black women, and all 25 specific indicator rates were more than 2 times higher for non-Hispanic Black than non-Hispanic white women. This slide shows results from our multivariate regression models of severe maternal morbidity. And as you can see here, adjustment for confounders in this analysis has only slightly ameliorated the unadjusted association for non-Hispanic Black women. And based on the adjusted analysis, non-Hispanic Black women have 2.1 times higher risk of having severe morbidity than non-Hispanic white women. The other significant predictors, positive predictors that we identified in this analysis were age, 35 and older, Medicaid coverage for delivery, poor socioeconomic status, and presence of a chronic medical condition. So the main take-home message from this analysis was that women's sociodemographic and medical characteristics did not fully explain the observed associations between race ethnicity and severe maternal morbidity. And clearly, there are other factors involved. We also looked at severe maternal morbidity rates by race ethnicity and mode of delivery. For all groups of women, morbidity rates were higher among women who deliver by cesarean than those with a vaginal delivery. Among racial ethnic groups, rates were lowest among non-Hispanic white women and highest among non-Hispanic Black women, irrespective of mode of delivery. But going back to our initial question, why isn't pregnancy getting safer for women in the United States? More women are delaying childbearing until their 30s. We've shown that rates of severe maternal morbidity are on the rise and disproportionately affect non-Hispanic Black women. Some of the increase in severe maternal morbidity is likely due to the increasing trends in cesarean delivery, and as others have documented increasing trends in obesity and chronic medical conditions, especially cardiovascular diseases among all women of reproductive age. All these trends appear to play out more dramatically among minority, Black, and Hispanic women. And also, differences in the quality of care offered in the various hospitals seem to exist. And other factors such as access to care, communications with health providers, other social influences should be considered by future research. In closing, I would like to outline some key future areas of interest in maternal health. Listed here are 3 areas of interest for us at CDC, as we are currently trying to find ways to more timely identify both severe morbidity and mortality. In terms of service utilization, we need to better understand health disparities. And in the U.S., we are mainly talking about income and racial ethnic disparities, which are highly correlated with each other and with poor pregnancy, maternal infant outcomes. Also, we need to understand the effect of the Affordable Care Act on women's access to care and their health, and find ways to further improve delivery of obstetric care to all women, irrespective of race and ethnicity. And last, quality of care has not received a lot of attention, but is now starting to be addressed by both clinicians and scientists in the United States. There is need to design and validate quality of care, hospital performance indicators, and there is need for user-friendly clinical protocols for management of the main contributors to mortality and morbidity in the U.S. And Dr. Main is going to tell you more about this during his presentation. Thank you.
Thank you very much, Dr. Krianda, for an awesome presentation. Our next presenter is Dr. Elliot Main. Dr. Main is the Medical Director of the California Maternal Quality Care Collaborative, and he chairs the first ever California Pregnancy-Associated Maternal Mortality Review Committee. For 14 years, he has been the chair of a very large obstetrics department at California Pacific Medical Center in San Francisco and is clinical professor of obstetrics and gynecology at both University of California, San Francisco and Stanford University. Through his career, Dr. Main's clinical work and publications have focused on medical complications of pregnancy and data-driven outcomes-based quality improvement. He currently chairs the National Partnership for Maternal Safety that has engaged all national maternity professional organizations on a quest to reduce maternal morbidity and mortality. Dr. Main.
Thank you very much, Kiva. I'm out here in California where it's still actually warm. Well, we're going to move beyond epi and surveillance to what can we actually do to improve maternal outcomes in the United States. We've gotten good direction from the CDC on these issues, and now it's up to us in the medical profession to see what we can do, particularly in areas where preventability is well established. We're not going to be able to cure poverty or social complexity and those kind of drivers for maternal morbidity and mortality, but we can have an impact particularly on hemorrhage, preeclampsia, DVT prevention, and those areas actually contribute a great deal to maternal mortality. So what I'm going to talk about today is really a confluence of multiple efforts that have come to join together here in 2014. We have the CDC ACOG Maternal Mortality Work Group that's been joining together the CDC and clinicians for a number of years. Chaired that with Bill Callahan, and over the last year and a half, we have reoriented that group to look at action as well as epidemiology. We mentioned the Society of Maternal Fetal Medicine and Mary Dalton's role in MBAC and MFM. And they set up some work groups. AWON, the Nursing Association, has also gotten engaged, particularly around hemorrhage. And then there's state quality collaboratives. ACOG District 2 and mine here in California have focused on hemorrhage and preeclampsia in terms of developing tools for clinicians, tools for hospitals, and tools for, as we'll get into hopefully, outpatient care as well. Merck for Mothers has been, in the past, focused on Africa and India, and they have recognized now that we have issues here in the United States as well, and they're putting significant dollars into implementation projects for some of the things that we're going to be talking about today, particularly hemorrhage and preeclampsia. If I have the next slide. So, as an outgrowth of the last ACOG CDC meeting and the other streams that we talked about in the last slide, we put together a National Partnership for Maternal Safety that has engaged the leadership of all the key provider organizations shown on this slide. So this includes ACOG, SMFM, AWON, the Nursing Association, the Midwife Association, the Anesthesia Association, and Family Practice, as well as the hospitals, blood banks, and birthing centers. These all come under the umbrella, actually, and fit very well into this multidisciplinary council of patient safety and women's health care that has vice president or president level people from all these organizations. This group met met together and endorsed the concept expressed in the next slide of having 3 maternal safety bundles. Our premise was modest, if you would. What should every birthing facility in the United States have for maternal safety? And the proposal is that every hospital, every birthing center should have safety bundles for obstetric hemorrhage, for severe hypertension, and for the prevention of deep venous thrombosis. The bundles outline the elements that one should have, but are not specific as to you have to have this specific protocol or that specific item, but instead give you a checklist of things that you should set up in your facility, and we direct you to resources that have been developed around the country that would fit your facility the best. So these come from New York, from California, from Florida, from many states have been working on this now, and it's a way of setting up an outline. In the next slide, you'll show again the collaborative in a visual diagram. In the circle, you have the direct providers, as we outlined. In our meeting in July, we also invited a variety of other key players for maternal safety, including those from the federal government, which was Maternal Child Health Branch, the CDC, and CMMI from the Center for Medicaid and Medicare Services. And we'll talk about their contributions, particularly of CMMI, for our hospital-focused approach. On the right-hand side, you see MCH branches and their associations that involve state health departments. On the bottom right-hand corner, that's not a direct provider, but it will show you is becoming a key partner, is the Joint Commission. The Joint Commission certifies 90% of U.S. hospitals and has a major commitment to quality and safety. Like the old E.F. Hutton ad used to say, when Joint Commission talks, people listen. And this is a very important lever to get the attention and resources from hospitals. In the lower right-hand corner are the perinatal quality collaboratives, which are organizing people at the state and local levels. And as we often are remembered to say, that healthcare is local. It happens at your hospital, in your hospital system, within a state, and things like Medicaid, which pays for half the births in the United States, happen at the state level. So we have to work both nationally in terms of surveillance and guidance and organizational, but we have to be able to scale it down to state levels and even lower with hospital systems. And that's what we're trying to do here. Go to the next slide. So our first key partner to talk about in this quest is the Center for Medicaid and Medicare Innovation. These are the folks that have gotten this very large amount of money from Congress to look at new ways of providing health care and to look at data-driven quality improvement. So they brought a Strong Start, which is looking at alternative models for prenatal care to prevent largely infant mortality and maternal morbidity, and also have put a very large amount of money into hospital engagement networks through the Partnership for Patients. This is engaging, next slide, 3,700 hospitals. So there are 27 hospital engagement networks around the country. They range from some that are single systems with 40 or 50 hospitals to the American Hospital Association, HRET, that encompasses 1,700 hospitals in a single engagement network. So these are focused on making hospital care safer, more reliable, and less costly, and it has 10 core patient safety areas, one of which is maternity care, and they are focused on reducing obstetrical adverse events. For the first 2 years, they focused on early elective delivery, and their partnership together with ACOG and with Leapfrog and Joint Commission has really made that a very successful initiative. In fact, it is their most successful initiative of all the 10 areas that they've worked on. They were at the meeting in July and saw the effort of all the different provider groups together, and they said that they wanted to partner with us. And so they worked it up pretty quickly, and now for 2014, the reduction of OB harm is one of the key targets, and it is harm from obstetric hemorrhage and preeclampsia. This is huge because this then gives direction directly to 3,700 out of the 4,000 or so hospitals in the United States to focus on hemorrhage and preeclampsia. And they have come to the provider groups to help design the safety bundles and the measures. Next slide. So the next key partner that came on board in July was the Joint Commission. As I said before, the Joint Commission as a regulatory body is heard in 90% of U.S. hospitals. And their contribution to this is to redefine what a sentinel event is. And a sentinel event means that a hospital needs to do a very careful analysis of systems improvement at the hospital to see where improvement opportunities could lie for future patients. They have, in their current guidelines, they've enumerated maternal deaths, but maternal deaths are about 1 in 10,000, 1 in 8,000 births, so that's not very common. And we wanted to work with them on redefining maternal morbidity as a sentinel event. And so severe morbidity was identified to go along with what Dr. Callahan was speaking to earlier, in line with Dr. Kilpatrick from Chicago's definitions that were 4 or more units of blood products and admission of the mother to an ICU. So we're looking for harmonization of these measures across from national epidemiology to local, and then to make them actionable. So the Joint Commission will, this is going through their final approvals, and we expect it by July of 2014, where the Joint Commission manual will say that hospitals need to very carefully evaluate these patients in what's called a root cause analysis. We've worked at ACOG to actually make a obstetric version of the root cause analysis, so it's more meaningful to do for obstetric services. But I think this will both gather attention and on these issues and provide resources for their review. Next slide. So the third key partner to go along with the provider organizations is the state quality collaboratives, and I've listed a few here. Our California group has published toolkits on hemorrhage, and just a week ago on preeclampsia, severe hypertension, that really lay out a roadmap of quality improvement, largely at the hospital level. New York District 2 and the New York Perinatal Quality Collaborative are doing the same from New York State. I've been to North Carolina earlier this month, and North Carolina is working on preeclampsia, and Florida is working on hemorrhage. Everybody is using and tweaking other people's tools so that we can keep them updated and learn from each other, but it's a very exciting business to be in right now. Other states are involved, such as Keystone in Michigan and Washington State Hospital Association, also working on these 2 topics. And we're working, actually, I used to live in Vermont and grew up in New England, and the Northern New England Perinatal Quality Collaborative, that's actually not the right acronym, but they have an interesting group of hospitals in Vermont, New Hampshire, and part of Maine that is largely has delivery services of 300 to 500 births a year. So they have different challenges, and they will be adding a very useful additional take on how to do these quality improvement projects in very small delivery services. Next slide. So what does a safety bundle look like? And this is our current draft of the obstetric safety bundle. Again, this is the outline of what hospitals should have to prevent mothers from bleeding to death. No mother should bleed to death in the United States in 2014. So it involves readiness, items that should be present on every unit, such as a hemorrhage cart, partnership with a blood bank, rapid access to hemorrhage medicines so you don't have to go to pharmacy to pick them up, and, of course, unit education of all staff to the protocols. Recognition, which involves every patient. So this is assessment of hemorrhage risk. Is this a patient who has had a prior obstetric hemorrhage and a prior delivery, or has placenta previa, things that you want to recognize prenatally or on admission and develop a plan for and get your blood bank prepared for. We want folks to do cumulative and careful assessment of blood loss because that drives our hemorrhage management plans. There is excellent data now from multiple randomized controlled trials and Cochrane reviews of the literature that oxytocin should be used after every delivery. You can argue whether it's IM or IV. You can argue whether it's with the delivery of the shoulder or the delivery of the placenta. Those are minor details, but oxytocin should be available in every unit for every birth. And then response is the key one. What we saw in our maternal mortality reviews in California when we examined the deaths from a quality improvement standpoint is that people didn't have a plan. They would do the same procedure over and over again. There was long delays in recognition, long delays in calling the appropriate people. And these are all remediable. These can be helped by having a stage-based management plan or hemorrhage protocol with a series of checklists. And these have gotten better and better and are meant to be individualized for each hospital as we go forward. But these will be given out as examples. Lastly, reporting and systems learning is establishing a culture of actually quickly reviewing your cases as a debrief after each severe morbidity event. Here, so we're talking about hemorrhage, but this also applies to severe hypertension or eclampsia or any other obstetric safety issue for that matter. In addition, as you've seen with the Joint Commission, these cases would be then eligible for a short root cause analysis where you look at all the contributors to the death or the morbidity and look for systems quality improvement. And then we have to have measures. So the next challenge is actually turning measures into something that's actionable locally. The next slide actually shows some resource toolkits, we can give you the full linkages to these and other resources that we're using with the hospital engagement networks, the HENS and all the 3,700 hospitals. But these are some of the hemorrhage ones. We have a big toolkit at CMQCC. ACOG District 2 is getting theirs up probably in the next couple of weeks. A1 has some materials as well on their website, called pphproject.org. Next slide. The hemorrhage guidelines. This is a typical hemorrhage management plan or protocol where it's stage-based with reminders of what to do and what to think about and how to keep your blood bank up to speed as what's going on. These are linked to a checklist. Example is shown on the right. Because there's many steps that one needs to keep in mind when you're dealing with a patient that has 1,000 or 2,000 mLs of blood loss, and that you want to, and this allows you to work as a team. And indeed, teamwork is really a spectacular part of this project, and it has enabled us to both develop the teams and then use the teams. Next slide. So let's talk about measures and how we can turn what you've heard from Dr. Callahan, Dr. Kriega, into measures that are used on the unit and measures that would be used to evaluate the success of the interventions that we're doing. These are ones that we developed collaboratively between the California Maternal Collaborative, the New York Collaborative, and the AWON Collaboratives, which is going to be in 3 states, Georgia, New Jersey, and D.C. The goal overall with hemorrhage is to reduce the overall use of blood products and the number of women who have massive transfusions by early recognition and early treatment of hemorrhage, but we don't want to discourage early appropriate transfusions, so there's a balance there. So instead of looking at the total number of mothers who got any blood product, we wanted to look at the total number of blood products per 1,000 women. So we're not so worried about a woman who gets 1 or 2 units. We want it not to spin out of control and have the severe morbidity. And so the total number of blood products is one measure that's been useful, and then the number of mothers receiving 4 or more blood products, which is again, the harmonized measure that Dr. Callahan spoke to and what we've gotten the Joint Commission to do, and what we want our CAs on. So again, the measure, we're trying to standardize the measures and have people counting the same things whether it's the Joint Commission or not. Next slide. For preeclampsia, what we found in our maternal mortality reviews is that far and away the largest cause of death in preeclampsia or eclampsia is stroke. And the largest contributor to that is the lack of recognition or delay in treatment of hypertension, particularly 160 or systolic or 110 diastolic, either one. Like with hemorrhage, we have we've run several 20, 30 hospital collaboratives and have field tested these. And we're looking to see if you have hypertension, whether you bring that blood pressure down with medicines within an hour. You'll be surprised the barriers that we uncover, and when you uncover barriers, that means you can have strategies to overcome them. The second measure here is the ICU days among mothers with hypertension. Again, this is then harmonized with the Joint Commission. If your mother gets admitted to an ICU, she could be there for pulmonary edema, or eclampsia or other complications, not just stroke, which is focused on by the second one. So right now, in the United States, I think we have an alignment of the stars for reducing maternal mortality and morbidity. The focus is going to be on morbidity, but the secondary issue will be mortality because that's the extension of morbidity here. But we have together, working with the provider organizations, which is the National Partnership, the Joint Commission, the HEN hospitals through CMMI, and the State Perinatal Quality Collaboratives. We are coordinating with the CDC and Maternal Child Health Branch, and more with state health departments and the public health departments, and with the Medicaid services, and consumer groups. So the challenge, I think, actually, is getting everybody to work together and be sure that we're coordinated, and that's actually a fair amount of my job currently. If we go to the very last slide, I'm just bringing this back to all the partners that we have at the table right now, working together on maternal safety, doing action projects around the country currently. So I'm actually much more bullish than I was a year or two ago about that we actually have now, this is a national agenda, and we have a lot of national organizations, state and local organizations working on this. And if you could push the button to show the last bit here, the challenge is keeping this all working together. So I think we've taken you through a grand tour of maternal morbidity today, from historical and measurement perspectives to an exciting action step here on what we can actually now do over the next several years. So thank you, and I'm happy to stay on and answer questions.
Thank you so much, Dr. Main. I'd like to let the operator know that we'd like to open the lines now for questions.
Thank you. At this time, if there's any questions or comments, please press star followed by 1 on your touch-tone phone. Again, please press star 1 on your touch-tone phone for any questions or comments. I'll take a moment for that, please. Please stand by for your first question. I do have a question from Ashanti Chimaranga. Your line is open.
Outcomes. Is there any similar data or findings in terms of disparities or differences in treatment, outreach, or any of the preceding events that help us to understand and explain the outcomes and help us focus our work?
I can start a little bit and then get some national perspective. This is Elliot from California. In our maternal mortality reviews, we certainly see issues around the accumulation of risk factors. One of the lessons that we've seen is that if you're African American and obese and older, you are at significant risk of cardiomyopathy. Many of our maternal deaths from cardiomyopathy fit that, particularly when you add hypertensive diseases onto it. And so there's got to be a heightened awareness that these factors are additive. Having said that, though, for example, with DVT prevention, one of the recognitions is, again, obesity and African American do seem to be additive together with a C-section. And so I think there's going to be changes in national recommendations about heparin prophylaxis for C-sections that we hope to make a difference in that. And African American women in California are heavier and they have more hypertension, so there is more comorbidities that we need to recognize and be on top of. I'll turn it over to others.
This is Andrea Krianga. Maybe just to add one of the limitations in our data, unfortunately with the NIS data we are using, we do not have the possibility of accounting for Kiva, do you want to intervene? No. So in our analysis, we cannot control for obesity or BMI. That's one of the major limitations in the data we are using for measuring severe maternal morbidity. Thank you.
Yeah, this is Bill, and we also in the administrative data, race and ethnicity is so poorly reported that we can't get at it very well. Hopefully we'll be able to look at that a little bit better in terms of some of the state inpatient databases, but even in those where the information we have is mostly related to outcomes and has very little about care, that's where review is really going to be key, because just as we've always emphasized with mortality, the same will be true with severe morbidity, that it's really the really detailed, granular review of care is hopefully where we identify themes and system themes that are going to shed give us some insight into what differences might really be going on with regard to differences in care and explaining disparities.
Hello, this is Jaquiba Henderson. I actually have a question if there are no other questions currently in the queue.
I'm showing no further questions.
I have a question for actually for whoever can answer, but first directly to Dr. Main. I was just wondering, with your working with ACOG and just being the head of an obstetrics department and working directly with clinicians, what is the feeling and the sense among docs about these bundles and different types of protocols and guidelines? Is there a feeling that people are trying to tell them what to do? Is there any pushback with having a set sort of guideline of how to manage a patient?
Sure. I was on a conference call yesterday with the largest HEN network, 1,700 hospitals, and there was a very nice presentation from Connecticut, and they've taken what we've done in California, reshaped it a little bit, and they don't call it a protocol, they call it a management plan, and that really resonated with me. But the reality is, hemorrhage is a well-recognized, pretty common obstetric emergency that folks really identify the need for help on, and recognize the advantage of having a team that knows what they're doing in an organized way, work with them on. And of all the different quality projects I've worked on over the last 15 years, this is the one that has, hemorrhage is the one has resonated the best with physicians, because they immediately see the results of, if you have a well-oiled team working on hemorrhage, you can have good success very quickly and feel like your butt's saved. There's nothing worse than having, seeing 1,000 mLs on the floor after a birth, and it's scary. And if you can have a team response, you immediately feel better as a provider, and obviously it's for the safety of the patient. So this actually, as a protocol for emergency response, is quite different than other kinds of protocols in medicine, because there's a lot of detail, a lot of things that are easy to forget. So this is well received. Of all the different quality projects, this is clearly the best received.
Has the same also been true for preeclampsia?
That's newer, and it's a little bit more narrowly focused than hemorrhage. The major things that we're doing with preeclampsia is, again, actually operationalizing the ACOG protocols for treatment of severe hypertension, using safe magnesium, and having people recognize preeclampsia a little easier. The definitions of preeclampsia changed in November, and we want to get a big educational effort to recognize, for folks to recognize it earlier in the office or in the clinic, and get them under care a little earlier so it doesn't, again, spin out of control. That's also going well. We have a 30-hospital collaborative running through this right now, and people are surprised with the barriers they're uncovering and that they didn't realize it existed on their units. And that's what this is all about, trying to sort the systems issues out ahead of time so that, you realize that, it's a big delay if you have to call down the pharmacy and get all the approvals before you get a medicine to the floor, or things like that. But there needs to be emergency medicines on our units. And staff has to understand that these are parameters that need to be treated and get those protocols going.
Are there any further questions?
Yes, thank you. I do have a question from Frances Kelly. Your line is open.
Hi, good afternoon. Really enjoyed the presentation. I just wanted to really emphasize that you absolutely hit on all of the top things that we're dealing with. This is Texas Children's Hospital in Houston and the Pavilion for Women. What we are finding, we have a postpartum hemorrhage protocol. Where we struggle, and I really want to get the feeling for those of you who have made the presentation or anyone else out there who could help us, is how best are you actually quantifying in real time? That seems to be a real barrier for us. And if you can contemporaneously quantify the blood loss during a delivery, whether it's a vaginal or C-section, if things begin to spin out of control, how does the team maintain situational awareness and effectively perform? That seems to be where we're struggling the most. And what we're focusing our efforts on at improving is how really best to operationalize our protocols, given our current culture. And I'll stop and let you guys answer. Thank you.
Okay. There are somewhat different answers for different hospitals how to operationalize. There's no question, though, that there are we need to move beyond estimating blood loss by a glance. One of the things that we've done in California is, and this is based because we have 500,000 births in California every year, is we were able to convince, as a state quality collaborative, all the major vendors of medical supply vendors to come up with under-buttock drapes for vaginal deliveries that have gradations on them. They're all conical in one way or another, but just having gradations allows you to really be able to much better estimate, it's not perfect, but estimate the blood loss as it goes forward. Certainly there's fluids that come out before birth, amniotic fluid, some urine, but that stops with delivery, and all the bleeding occurs after the baby's born, typically after the placenta is born. So that's a zeroing point that you can do. Some hospitals have been very successful measuring weighing saturated pads, or others have done educational efforts around that. AWHONN is taking a leadership role in this, and I would refer you to their website. They have a lot of good materials there, and we'll be adding more. Our new toolkit is coming back out, but it's more about being intentional and having a realization that this is cumulative. If you can bleed maybe 500 delivery, and then the provider may leave, and then 30 minutes later you could bleed another 500. And the key is knowing that it's 500 plus 500. There is a balance about paying too much attention to trying to quantify the blood loss versus paying attention to the patient. But that's a medium that you need to get. So I would find a nursing champion and the physician champion in your hospital and have them sort these out. But I would do the least, quote, interventive ways of measuring blood loss and just work with those. I hope that's helpful. I would refer you also to AWHONN and some of the CMQCC materials.
Thank you so much.
Thank you, and I am showing no further questions. I'm sorry, I do apologize. I do have a question now from Victoria.
Okay.
Line is open. Thank you.
Actually, it's Chris Cuss from New York State, and this is for Dr. Callahan. You talked about the measure of severe maternal morbidity for the U.S. using the national data set. Is it possible, or is there a data set that you can calculate state-specific severe mortality?
Severe morbidity, yeah, there is. And I'll let Andrea chime in too, because she's really a lot better at the granularity of what's in the state inpatient databases. But the nationwide inpatient sample is produced by Agency for Healthcare Research and Quality, but states also submit their own state inpatient databases to them, and not every state participates, but I'm almost positive that New York does. And there is a state inpatient database that has all the information of the nationwide inpatient sample plus more. Yeah, it's doable to do that at a state level. Andrea, please chime in if I've misstated anything about that.
No, I think you're perfectly right, Bill. Most of the states have SIDs, that state inpatient databases. These are data collected on a regular basis that AHRQ just tries to compile and standardize in a way that researchers can use for comparative studies and such. New York State has, I would say, some of the best data, SID data, only if you are to think about the availability of the number of blood units transfused during the hospital admission that already applies for the NIS data. And I think one of our colleagues and collaborators, Jill Meyer, Brian Bateman also, they have looked at this data, and I think a paper has already been published in the Green Journal. So I fully encourage you to use these state-level data. They're very rich, and they can give us a sense of what's going on at the state level, and we can make comparisons with the national level data we have.
So let me just add to that. The metric that Dr. Callahan presented is based entirely on ICD-9 codes. So that is available in many states with that kind of a data set, a patient discharge diagnosis data set that many states have. I think what is more, may be more additive, and we're actually looking to study this, would be the ability to capture the number of units, patients who exceed a number of units. So that's a little bit more granular, and that's not typically in the patient discharge diagnosis set. But that is available typically from hospital blood banks and from their charge masters, and that's what we're encouraging the HENS to do. And I think this is an opportunity, again, to collaborate of the different projects here, is to have the HENS, and I think New York State is, most every hospital is in a HEN, Hospital Engagement Network, and if they're all collecting the same measures, I know ACOG District 2 is very engaged with this and looking at wanting to push these measures, that you could collect statewide these same measures that we're talking about, both the high-level ICD-9 code data and then the ICU admission, because that's from the charge master. And that can be easily downloaded. I'm doing that in Washington State and in a big collaborative in California as well. So you can get the data from the charge master for ICU days and the charge master typically for the blood product utilization.
Thanks. So this is Chris again. So as I understand it, for a high-level measure for a state to track their severe maternal morbidity level, we would be able to do that using the state inpatient data set. Is that right?
Yeah, we think so. You know, our caveat about tracking that is, it is what it is. It's not going to, it's administrative data with all the flaws of overcoding and undercoding that it has, but at least, especially in terms of trends, we think that it, you know, assuming that those kinds of issues don't change much over time, we think it's measuring some index of severe morbidity, and the fact that when we went into the nationwide data set, found all of the women in the data set who during a delivery hospital discharge status was that they had died during their delivery hospitalization. We were able to tie those indicators to those deaths, so we think that they're proximately related to death. We think that they are severe. And then it's a matter of breaking it out. I think it's reasonable to break out the transfusion data separate from everything else, because unless you have an indicator of how many units were transfused, we don't want to make the mistake, as Elliot alluded to, that giving a woman 1 unit of blood is something that we need to be really wary of. In fact, there are times when we know that giving a woman a unit of blood is actually the right thing to do and will save her from massive transfusion. So yeah, we think at the population level it's a reasonable thing to do.
So that's helpful. So at least we should look at that. We know we've got the caveats, but given this, that's something to take a look at.
Absolutely. And as Andrea said, the New York State Inpatient Database actually does have a number of units because we've used that before. Not all states have contributed to that. Most states have some inpatient database that's through their hospital association or whatever. There's only one state that I know of off the top of my head that I've heard of that doesn't have an inpatient database.
Also, if I may add, this is Andrea. Most states now have ICU admission data. So if you are to have both number of transfusion, units of transfusion, and ICU admission data, then you can pretty much apply the new measure that is going to be that was presented by Dr. Callahan and is going to be supported by the Joint Commission.
This is Chris. Can I ask one more question?
Yes, and we have additional person waiting.
Okay, that's fine then.
I think we have a couple questions that are waiting, and so we want to give as many people opportunity to ask.
Okay, thank you. And I do have the next question from Carla Clark. Your line is open.
Hi, good afternoon. Thank you all for such a great presentation. We just wanted to to add to the current discussion about utilizing the state databases, we here in New York City are actually planning to begin surveillance for severe maternal morbidity using the SPARCS data system. And so that contains the delivery and postpartum hospitalization data. And to sort of support that, we also want to link it to our birth certificate data so that we'll be able to have a little bit more rich information regarding the race, ethnicity variables, and those sorts of measures, socioeconomic measures.
Yeah, that's awesome. I mean, clearly data link, when an entity has the ability to do linkages, the opportunity to add so much, another level of richness is really there.
Great. Thank you all for a great presentation.
Thank you. Our next question comes from Namaco Brown. Your line is open.
Hi, yes. My question is related to C-sections. And so I'm based here in New York City, and the rate of C-sections in our hospitals has drastically increased over the past 10 years. We're up to 40% of all deliveries are done via C-section. So I want to know, how does the increase in C-sections contribute to the rates of maternal morbidity and mortality? And as a follow-up, are there any discussions happening about ways to reduce the number of C-sections?
As the clinician on board here, the active clinician, let me take a first stab at it. In the maternal mortality review committees, we did note that 70% of maternal deaths did have a C-section, but a very large number of those were perimortem, i.e. was done because the mother was in extremis. There was a small excess of clearly procedure-related deaths that were, you would say, everyone would agree to. DVTs, for example, postoperative sepsis where there was not infection before, and very small number of anesthetic complications. Morbidity is probably where C-sections play the biggest role, and that may well play, as I think Dr. Criaga mentioned earlier, the association with increasing rates of hemorrhage in the United States and in other industrialized countries where C-section rates and inductions have gone up considerably. We certainly are seeing placenta complications in subsequent pregnancies, more placenta previas, more placenta accretas, which are often result in a hysterectomy and can have life-threatening or life-taking hemorrhages. So there is a clear relationship between a high C-section rate and more hemorrhage. How much additional morbidity is a little less clear. There is a growing interest in reducing C-sections and a growing agenda being developed on that. So I see the payers and purchasers are very engaged on this right now, and I see this coming out nationally within the year. You're going to hear a lot more on this. ACOG is getting behind this with some very good documents coming out about labor management, which is one of the big drivers here for the primary C-section.
Thank you.
We just saw last week or 2 weeks ago published that we hope it is encouraging news, and that's for the first time in almost any of our recent memories. There's been a modest but real decline in primary cesarean sections in the United States between 2009 and 2012, and it declined in most states in the country, not all, but most, and greater in some than others. Some people are looking at the success in reducing elective delivery less than 39 weeks without an indication, and how that might relate to cesarean section. I'm not willing yet to say that we have anything more than circumstantial evidence that those are connected, but we could certainly come up with mechanisms about if you induce fewer women at 38 weeks and to the degree that induction might be related to ultimately being delivered by cesarean section, that those women that weren't induced at 38 weeks may present in spontaneous labor at 39 weeks and go on to deliver vaginally. We can all come up with those kinds of constructs about how that might be working, but I don't think we really have the data to say that's the mechanism for the decrease. We hope it is.
I think the bigger issue is potentially changing the culture away from a lot of interventions, and that could have carryover, but that would be one of those constructs that Dr. Callahan was speaking to that we have to test. But a lot of C-sections are related to the culture of the unit.
At this time, I'd like to give a special thanks to Drs. William Callahan, Andrea Trianga, and Dr. Elliott Main for giving us excellent presentations on severe maternal morbidity. We would also like to thank you all for participating in this webinar, and we invite you to provide feedback about this presentation and the webinar series as a whole. We'll be contacting you after this webinar for your input. I would also like to remind participants that handouts for these presentations are available for download. If you just click on the handouts icon on the upper right corner of your screen, it's right next to the notes icon. And we also hope that our webpage and this webinar series will facilitate exchange of information and promote visibility of perinatal quality improvement activities throughout the country. We encourage you to visit our webpage to learn more about CDC support of perinatal quality improvement collaboratives and severe maternal morbidity. You may also contact us by email at drhinfo@cdc.gov. That's drhinfo@cdc.gov. Thanks again and have a wonderful afternoon. This is the conclusion of our presentation.
Thank you, and you may all disconnect at this time.